My name is Dr. Patrick McGahan, and this is a presentation on shoulder replacement ranging from reverse arthroplasty to anatomic shoulder arthroplasty. I am a board-certified orthopedic surgeon that practices in San Francisco, California. My specialty is sports medicine and shoulder replacement. Reverse and anatomic shoulder arthroplasty is a safe, effective, and reliable treatment for shoulder pain. In the right hands, it has a 95% success rate and a good long-term prognosis at 15 years. Today's talk will start with an introduction on the anatomy of the shoulder. This will be followed by causes of shoulder pain and initial conservative treatment options. Following this, I will discuss surgical options. We will then finish the talk with real live case examples. The anatomy of the shoulder is complex. It's a ball and socket joint. The joint is surrounded by the rotator cuff muscles. The ball is composed of the humeral head. The socket is like a golf tee and is called the glenoid. Together, these are surrounded by a fibrous joint capsule. As demonstrated here, the shoulder is a synovial joint, which is a ball and socket. The joint is surrounded by a capsule. Inside the capsule is the cartilage. Wear of the cartilage causes pain. When we give injections, we give the injection into the synovial fluid, which bathes the joint. The shoulder joint is surrounded by the rotator cuff muscles. These are composed of the supraspinatus, infraspinatus, subscapularis, and teres minor. These muscles are important for powering the joint. As we'll discuss later, when these muscles are not present, then a patient is a good candidate for a reverse shoulder arthroplasty. Finally, the anatomy of the shoulder joint is complex. There is a complex interplay of static stabilizing forces and dynamic muscular forces. The interplay of this anatomy is what determines whether or not a patient gets a standard shoulder replacement or a reverse shoulder replacement. There are many causes of shoulder pain. The most common are osteoarthritis, rheumatoid arthritis, and rotator cuff tear arthropathy. Rotator cuff tear arthropathy is a condition where a patient has both a rotator cuff tear and arthritis. The other major cause of shoulder replacement is previously failed shoulder surgery or severe fractures of the proximal humerus. The most common cause of shoulder replacement is osteoarthritis. This is degenerative joint disease which results in cartilage degeneration and eventually bone-on-bone contact. This is typically age-related. The main symptoms are joint pain and stiffness. As you can see in this normal shoulder x-ray, there is space between the humeral head and the glenoid socket. In a patient with osteoarthritis, the cartilage is worn down and you can see the bone-on-bone configuration as well as the bone spur formation. Rheumatoid arthritis is another cause of shoulder replacement. This is a multifactorial disease but is thought to have a genetic basis. In recent times, advances in medications have made the disease more manageable. However, there are still patients that eventually need shoulder replacement due to progressive joint destruction. As seen in this x-ray, rheumatoid arthritis causes progressive joint destruction, which is characterized by bone spurs as well as erosions of the humeral head. Another cause of shoulder replacement is avascular necrosis. Avascular necrosis is a disruption of the blood supply to the humeral head, which results in bone death and destruction of the glenohumeral joint. Although there are multiple causes of avascular necrosis, it is often the case that the cause is unknown. As seen in this x-ray, there is collapse of the humeral head. It has lost its circular shape and there is now bone-on-bone arthritis. There are multiple other causes that can lead to reverse shoulder replacement. One is post-traumatic arthritis, such as an athlete that has sustained an injury earlier in their career. The other is rotator cuff tear arthropathy, which is an increasing cause of a need for shoulder replacement. When the rotator cuff fails, the shoulder joint becomes disabled, and this often necessitates the need for reverse arthroplasty. Another common cause of shoulder replacement, as seen in this x-ray, are severe fractures. When a fracture cannot be appropriately fixed, the best option is a reverse total shoulder arthroplasty. When I see a patient with shoulder arthritis, I always start with conservative care. Conservative care consists of over-the-counter medications such as ibuprofen and Tylenol. Once a patient's pain is severe enough to warrant narcotic pain medications, I strongly recommend shoulder replacement. We often try physical therapy as well as cortisone injections. Cortisone injections are safe, effective, and are low cost. However, they often provide only temporary relief. Newer treatment options such as platelet-rich plasma can provide more lasting relief. However, unfortunately, although these have good results, these are not covered by insurance plans and come with a high cost of approximately $800 per injection. Finally, when conservative measures fail, shoulder replacement is the best option. In terms of shoulder replacement, there are three options. One is a total shoulder replacement. The second is a resurfacing replacement where only the humeral head is resurfaced. And the third is a reverse total shoulder arthroplasty. Total shoulder replacement resurfaces both the humeral head as well as the glenoid. Like a hip replacement, it replaces the ball and the socket. The sizes are variable and they are matched to the patient's specific anatomy. These are typically press fit so that we do not need to use cement. This is a safe, reliable, and reproducible treatment that results in good pain relief and restoration of function. However, it should be noted that in order for this prosthesis to function effectively, a patient needs to have an intact rotator cuff. The second option is a resurfacing hemiarthroplasty. With this replacement, the humeral head is replaced, but the humeral socket is not disturbed. This is a good treatment option for younger patients. However, once you have bone-on-bone arthritis, this treatment option is not as reliable as the native glenoid can still cause pain after resurfacing hemiarthroplasty. However, in patients under age 50, this can be a solid treatment option. The final treatment option is a reverse total shoulder replacement. This is the fastest growing treatment option for patients with shoulder pain. This is due to the fact that a reverse shoulder replacement is an appropriate option for many different shoulder conditions. This includes severe arthritis, rotator cuff tear arthropathy, revision surgery in the setting of previous shoulder surgery, and severe fractures. A reverse arthroplasty is called reversed because the ball and socket components are reversed. The socket is placed on the humeral head and the ball is placed on the glenoid, which is reversed from the standard anatomy. However, despite this change in anatomy, the reverse total shoulder arthroplasty has shown great results with a low complication rate. So what are the potential risks of shoulder surgery? Any surgery comes with a discrete set of risks. Although shoulder replacement is a successful surgery, there are risks involved. However, I would place the estimate of major risks at less than 5%. The risks of total shoulder replacement include infection, prosthetic loosening, dislocation, nerve or blood vessel injury, postoperative stiffness, and rotator cuff failure resulting in the need for revision surgery. Although these risks are real, taken together they represent a low overall risk to the patient. In terms of surgery, there is a standard protocol that I use. A shoulder replacement takes approximately 2 hours. This is done under general anesthesia with the patient asleep. However, we do use a nerve block for pain control. No blood transfusion is necessary. For younger patients, we can perform this as an outpatient surgery where a patient goes home the same day. However, for most patients, we keep you overnight and you typically go home 1 to 2 days after the surgery. Postoperatively, we use pain medications and a nerve block for pain control. In terms of recovery, we ask that you keep the dressing dry for 2 weeks. We do, however, place a waterproof dressing, so in case the dressing does get wet, there will be no issues. It is okay to shower with the dressing in place. We typically remove the sutures at 2 weeks. We begin standard physical therapy approximately 1 to 2 weeks after surgery. We ask that you wear the arm sling for 6 weeks to protect the repair, and we ask that you do not drive for 6 weeks after the procedure as you will only have the function of one arm. In terms of physical therapy, we start therapy immediately postoperatively with pendulums and active wrist and elbow range of motion. For the first 8 weeks, we limit you to passive range of motion as well as active assisted range of motion, such as using pulleys. At 8 weeks postoperatively, we then begin active range of motion. For a total shoulder replacement, we do adhere to subscapularis precautions. In terms of recovery, full recovery for a standard shoulder replacement takes approximately 3 to 6 months. In terms of a reverse total shoulder arthroplasty, recovery is often quicker at approximately 3 months. Now I would like to discuss some real patient cases. This is a 65-year-old woman with right shoulder osteoarthritis. I treated her with a standard total shoulder replacement. The postoperative x-rays show the prosthesis in the appropriate position. This is my patient in 3 months follow-up, and she is very satisfied with her procedure. As you can see, her right shoulder has very good range of motion. If you watch closely, her right shoulder has slightly limited range of motion compared to the left side. However, this is within normal ranges, and the patient is functionally doing very well and can perform all her activities of daily living without difficulty. The second case presented is a 55-year-old woman with severe osteoarthritis. As you can see, she has bone-on-bone osteoarthritis of the glenohumeral joint. In addition, she has wearing of her glenoid as well as the rotator cuff. In this patient, I chose to do a reverse total shoulder arthroplasty due to the severity of her arthritis and the thinning of her rotator cuff. As you can see, the postoperative x-rays showed the prosthesis in appropriate position. Postoperatively, the patient did very well and was very satisfied with her shoulder surgery. Again, as you can see, the reverse arthroplasty results in a great improvement in range of motion and restoration of all of her activities of daily living. The third case is a patient with left shoulder arthritis. Postoperatively, you can see a left reverse total shoulder arthroplasty in anatomic position. This is an axillary view showing the prosthesis from the side and once again in appropriate position. In follow-up, you can see that the patient has regained great range of motion of her left shoulder. Again, if you watch closely, she has lost perhaps 5% of her terminal range of motion. However, the patient does not notice this, and she has regained all of her function and can now do all of her favorite activities without difficulty. The final case is an interesting case of a patient that has undergone bilateral shoulder replacement. On the right side, she underwent a standard total shoulder arthroplasty, and on the left side, she underwent a reverse total shoulder arthroplasty. This is a preoperative MRI of her right shoulder showing bone-on-bone arthritis and significant inflammation of the joint. This is an axillary view, once again showing bone-on-bone arthritis, bone spur formation, and significant inflammation of the joint. As you can see from this x-ray, she was treated with the right total shoulder arthroplasty. On the left side, she is treated with the reverse total shoulder arthroplasty. The difference for procedures is due to the fact that on the left side, her rotator cuff was torn. On the right side, her rotator cuff was intact. For a patient with an intact rotator cuff, I prefer to use a standard total shoulder arthroplasty. However, when a patient's rotator cuff is torn, then I use a reverse shoulder arthroplasty as seen on the left side. This again is a postoperative x-ray showing the arthroplasty in appropriate position. As you can see in follow-up, the patient is doing very well with respect to both of her shoulders. Again, the right side was treated with a standard shoulder replacement and the left side treated with the reverse shoulder replacement. On this video, it's difficult to tell which side had each replacement as the patient is doing very well and is very happy with her procedure. So in summary, I am a board-certified orthopedic surgeon that specializes in shoulder replacement. Shoulder replacement surgery is indicated when a patient has pain and stiffness in their shoulder and conservative treatments have failed. There are 3 main types of shoulder replacement: total shoulder replacement, resurfacing hemiarthroplasty, and reverse total shoulder replacement. Optimal results requires active patient engagement and proper understanding of the treatment as well as the postoperative physical therapy. For further information, you can visit my website or the website at the American Academy of Orthopedic Surgery. Thank you.